giving his regards to you. He's saying hi to you.
Amit,
So
so
can you
nice
give him
to
a mic,
see you
please, so
guys
he can make
together.
some comments, and then. So what we decided is that I'm gonna do 2 layers, and then he can come and do other 2, and you can make some comments. So we are giving a mic to him. So both of you can interact, and I'll also interact in between. Is that okay, Manuel?
Yes, perfect.
Okay, okay. So guys, everybody, good evening. I have with me my teacher, my mentor, Professor Galvao Neto. I think he's one of those endoscopists who have taught. So people have records in performing endoscopic surgeries. Manuel has record both in performing endoscopic surgeries and I think training the maximum number of surgeons across the world. So not only that he is a great surgeon who must have done more procedures than anybody across the globe, but he has trained many surgeons and fellows like me to be able to perform endoscopic procedures and to benefit to the patients across the world. So proud to be associated with him and so honored to have him while operating live, and he's making some comments here. We are live on Zoom. The last case we did, we were live on the Facebook, and we had some great comments made by some of the surgeons and some of the questions. So Manuel, as you can see that I'm just trying to take the first layer here. So if there are any suggestions or comments, please do make so that everybody can. I hope you are getting a good view. Is the view okay?
Yep, everything is fine, and thank you very much for having me. It's an honor and a joy to be among you and Amit. So my heart is just happy.
Thank you.
So it's where we can see that what you are getting, and as you pass the learning curve, everybody tries to do what you're doing is to achieve a full thickness bite. And sometimes as you get full thickness, it just happened with you here. You're not able to exchange the needle. When
I
it's not on you,
is
easily,
as full as possible. But if I'm not able to exchange it, I can always, go back and revise it. So that's
exactly
fine. Happens.
Yeah, and it is not on you. It's on a limitation of the device that sometimes cannot handle a lot of tissue. And it seems that in this particular patient that the tissue is a little bit thicker, no?
So I don't know if you remember, we were at Nageshwar Reddy's place, and you were trying to exchange a device, and it did not. And there was nothing wrong with the device, but it's just now see it exchanged. So I think it's the way this device has been made. It's probably the nature of the device. I don't know.
Exactly. Yet it is the nature of the device, and sometimes the thickness of the tissue they cannot handle that, and that is what is due to the operator to have the sensibility to check if it's gonna be able to exchange the needle or not, as you're doing right now. And is what I like is that you're going very parallel to the incisura angularis. So for the ones who are listening to us,
I'm trying not to obstruct the lumen, So
exactly. And by doing what you're doing, you cannot do that.
Yeah.
Yeah, you see, just the maneuver to get the full thickness bite that I love. And
that's what you have been teaching me last so many days. I remember when we were doing my first or the second case, this maneuver looked to me as one of the most difficult things on earth. And when we sort of practice it now, it comes so naturally to us that
yeah, and it is what everybody thinks on the beginning. If you just balance your body a little bit for your right, you're gonna have better checks. Sometimes a little bit movement like what we call an air guitar movement, so like we're doing right now. So it facilitates the exchange what you're doing now. So always is like this, because what we don't have here is that the ability of move the thing. So once you get the tissue with the helix, you are like attached to the tissue, so your needle holder have to move around this helix as you're doing now to get the good bite. And that's it. For the ones who are watching us, this is very important. So on your right ear is the smaller curvature in the incisura. So what Mohit is doing now, he is getting back to the way he began in a U shape on that. And what you see here that some surgeons, or some gastroenterologists, like Mohit, they wanted to start like moving more on the middle to the anterior wall in the beginning. And some like me like to go from the anterior to throughout the greater curvature and the posterior wall. It doesn't matter. At the end, what does matter is you tubulize well and you get full thickness bite. And you can see here, and it's like a ballet, a dancing, because as we stated before, we have limitation of moving the instruments. So your body have to go that. So it's really important that we have a perspective in the sense of what's happening outside, because we can really translate outside with inside movements, as you can see here, with the flawless and seamless movements of Mohit from outside. So you have to just to connect here. Then it is a little bit difficult on the beginning to understand the anatomy, but basically you have to take in mind is that you have a smaller curvature on your right side of the screen at 3 o'clock, and then you have the greater curvature at 9 o'clock, anterior wall at 12 o'clock, and posterior wall at 6 o'clock. And you have to deal with that and understand the anatomy is a key for the procedure. And both GIs and surgeons can do that. So I don't know if Amit want to do any comment on that, or you.
Your comments? Oh, he's okay.
He's joining the live.
I'm just listening. I'm just listening.
He's listening.
You
He's
see,
smiling.
yeah, this is a very good first ring that you did it. So I think that you just dropped the needle, and now you're gonna about to
the needle,
cinch.
and I'm now gonna cinch it. So then we're gonna go.
Yeah, and something that you didn't mention that you have to mention to everybody that is very good to do is before you cinch, you do a pre-suturing, a pre-tying, because you pack everything together and then you put and you don't put the pressure on the cinch. So.
Okay, looks good.
Looks good.
Okay.
Looks good indeed, sir.
Now we can go. We can move a little bit back and start with the second suture. You know, Manuel,
Yeah, and
I'm
it's
operating
beautiful
on
how you can see the greater curvature. Go ahead, please.
Yes, I'm operating on a 60-inch screen.
Oh, 60-inch screen.
60-inch screen. You know, it's the largest I have ever seen this. It's the largest I have ever seen this.
Oh, so now I understand why Amit is speechless.
Why? Why?
Why Amit is speechless?
I'll be the same when I get there, my friend, because 60-inch screen is something out of this world.
Oh, it's the store's 3D 4K screen. It looks beautiful. And I mean, I think endoscopic vision with the passage of time is going to improve only, I feel. That they...
Yeah, we have to cross the barrier of the 1K, and Amit might comment on that because he works so close with the endoscopic industry. Do you think, Amit, that we are near to get over the 1K image to the 4K or 2K, or are we still gonna have to live with the 1K image?
He's asking you.
What is the question?
He's saying you think that we need 4K in endoscopy. 4K.
This is what?
4K.
This is 4K.
No, I understand. This is a 4K image that you see, but you're not broadcasting 4K. You're not getting out 4K.
Yeah.
Because you're using a 119 tower. 119 tower is 1K.
Exactly.
So your monitor is 4K. Get better, but it's not.
It depends upon the processor.
Yeah, it's. I think now the endoscopy, they are also improving the vision. I guess that they.
But here, more than the 4K manual, it is the size of the screen. So
yes,
this is like sitting in a movie theater and watching your.
Yeah, that is
the reason
we need it.
And of course, Mohit's skill.
That's it.
Mohit's way of doing it and your commentary. has made me speechless.
he's he's very benevolent. He's,
Mohit, if you don't mind to comment on us that we are watching here,
no,
how do you sense, how do you balance that you're not getting structures outside with your helix?
okay, so usually what I would do if I am trying to take a suture and I'm trying to pull it from the helix. So for example, now here I pull it, and suppose I'm not able to pull it. It means that I am stuck to some adjoining structure outside. Now you see, Manuel, this is so loose, Can you see this?
Yes,
If I
I
try,
do.
if I try and drill with the corkscrew a little bit more, and then it's tight, I have to loosen it, because then there is a possibility that I am uh, taking some tissue which has a surrounding structure adhered to it. So that's what I keep in mind. That's
Yeah.
my way of judging it. Plus,
If any extra gastric structure comes, then you just can't pull the tissue inside.
absolutely, that would be stuck, and then you have to again loosen it up and restart the process again. So that's the best way. I have another question. I was operating at Dr. Palanivelu's place, and I had a very interesting incident which happened with me, Manuel, and this is something which kept me awake the whole night. I was operating, and me and Abhishek, we started corkscrewing. Manuel, can you hear me?
Yes, I can hear you.
Yeah, so we were doing the
I'm paying
corkscrew.
attention.
Yeah. We were doing the corkscrew maneuver, and suddenly I felt a give, which means I probably entered through the stomach outside. That's what I felt. I don't know. We kept on suturing that area, and we completed the case. The next day we did a dye study. Everything was fine. But do you have any such experience where you started
at least four or five times?
Okay.
It sometimes happens. Go ahead.
Just teach us about it. What's that experience? What do you think must have happened, and how do we manage such a situation if we have a give?
Well, my friend, it's first you freeze. It's something that you say, "Oh my God, what just happened?" Because your helix just got out on the wind, and you feel that you're getting inside the cavity, and you are. Nothing. Good thing. Probably nothing gonna happen, because you're gonna cover this hole.
So in your
you're gonna cover this hole with suture.
In your 4 or 5 cases, Manuel, these patients did not have any major problems, complications when it went
Zero.
Zero.
Zero. We
No,
are doing on
in fact,
two.
Even in my case, I never encountered. Me and Abhishek, we were discussing that the whole night. That we're gonna call Praveen and gonna ask him that how the patient is doing, because we were scared. Now see this. Now see this. Initially, I was not very comfortable. So Abhishek immediately, he's so smart that I do not look embarrassed on the screen. He would immediately unlock it, unscrew it without anybody knowing that that, and it probably was into an adhering tissue. And it depends upon the experience of how your assistant behaves. So
Mohit, if I may, and Amit, I will try to explain to you guys why this happened. This happened when we are trying to get a tissue that is very stretched and very tense, or you're doing a stitch very near to the order, and there's not space enough to do that. And the key point here is that respect the folds. When you see folds, it means that the tissue will come to you. So when you go in a bold place of the mucosa, especially when you're getting near to the smaller curvature, sometimes the tissue is so stretched that as you try to pull them or to getting that, it goes inside. It's a matter of, and all the times that happens to me or people that I was helping or teaching, it was on areas that we didn't get a fold, and or it was over distended, or it went stretched or near to the smaller curvature, and that's what happened. And again, it's very concerning. During the time you freeze and say, what's happening? I don't know what. I something very weird. But on the practical ground, you just suture over and everything is fine.
Okay. Okay. So are you happy as of now, Manuel? Are we going fine?
Yes.
You can see a
So far,
beautiful
you're
tube
doing
in the
great.
making. Yeah.
And if you can please use your helix to show us the
Okay.
the lining forces. So when you're doing the tube, the stomach shows you where you're
Absolutely.
gonna
Absolutely. I'm just going to
get that.
demonstrate
So
that.
if you
So
do, yeah, if you
I loaded
demonstrate
my
that
needle and
for
now
us,
I'm going
gonna
to
be nice.
demonstrate. Absolutely. So that's,
Please,
yeah.
please.
So, okay. So now, as you can see, just put a little bit of water to remove these bubbles. So now, as you can see, this, here, here, these are the lines of forces. These are just the bubbles. So I'm going to just remove them. If we just put a little bit of water to, okay, now it's better. So you see this, there are already folds which are, so I'm going to start from, so here, 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 and then I'm going to come back here. Then I'm going to back this, 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 and at the top. So that's what I'm going to do. And I think I can see it clearly that this was my last area where I took a stitch, and I'm going to start from somewhere from here. Okay.
And now I want to ask a question to you both, and I want different specific answer from you and from Amit. Let me start with Amit. So
Okay.
guys, we just, you know that we just published the Brazilian consensus of ESG, 1,828 cases, and it's a very interesting series. And also what I wanted to ask you, how happy are you with this procedure in your clinical practice? So what is happening with your patients in terms of results, failures? So what you guys seeing? I can share with you guys that we have around 5 to 8% of failures that we, or not failures, or patient that non-response that you get have to go back and do resuturing or refer to surgery or things like that. But we are getting my critical mass of our follow-up is getting to the second and third year now. But I wanted you to share with the people that are watching us what's your experience and how happy you are with this procedure, what's your perspective, what is needed to be done in your country, India, this should be a success. So Amit, if you comment on that.
Yeah, good question, Manuel. Because in India, to tell you the truth, we are still struggling to convince the patients to get this procedure done. Because even if we try to tell them that this is not a surgery, this is not cutting the stomach, it's just a simple plication of the stomach, still patients are shying away a little bit from this procedure. You know, even though they don't want surgery, that is one aspect. Second aspect is, in spite of that, whatever procedures we did, at least in our center in Mumbai, at least in the initial stages, when in some patients where the weight loss was not as expected, in spite of they following the diet which was prescribed by or given by our dietitian, very strict follow-up, proper contact. In spite of that, when we looked inside, quite a few of our sutures had loosened up. And after I came to know that you guys have started the merit trial in US, you know, and you mentioned to me couple of times that you are doing the reinforcement, and I asked you how we should do it. And uh, over the last 10 patients of mine where I did the reinforcement, I do not know, maybe because my own experience had become better or because it was because of the reinforcement. But these patients did extremely well. In whichever patients I did reinforcement of the sutures, especially the first 3 sutures, just proximal to the incisura. And these patients have done extremely well. Their weight loss has been very good. The patients have been very happy. So that is my take on it.
Now, Manuel, we are here in a situation where our needle exchange, suture exchange catheter is going to stuck there. Can you see that? Hello? Manuel, am I with you?
Are they with us? I think not. They are disconnected.
Now I'm back. Now I'm back. I'm seeing the situation. That's why I was talking with Amit to give you space. But please explain to me what is happening.
Okay, see, now the needle exchange catheter is stuck. I'm locking and unlocking my needle holder, but I'm not able to get it disengaged. Maybe my needle is broken, or maybe. So what's the way now?
Yeah. So let me get your let me get your image here. So open and can you please put the image on your handle?
Okay, just change the image.
Okay. Yeah. Exchange the image. Let me check. You're free.
Yeah, I'm free now. Okay, so
let's see if the needle exchange or not.
Yeah, so no, I just
first thing, rotate your scope to the lumen. Good. So now try to close and open the jaws.
Okay. We'll just try and pull the scope if we can just.
But before you do that, it is closed or not?
No, it's not closed. Let me close it.
So what you're gonna do possibly is a device malfunction.
Now we can.
So what you're gonna do is that, but before you do, yeah, good. Now we're gonna see what happened.
Yeah. So let's demonstrate what happened, because this is something which happened to me for the first time. So we're gonna learn slowly.
Me either. I don't know what happened.
Okay, now let's see this.
Check if you, Mohit, you should have the suture there.
Take out the blood.
No. The issue is that, can you see there, Manuel? We have the needle there. Just focus there so that we can learn from this. And next time we don't do it. So you can see that the needle is outside.
Yeah.
At the same time, we close, the needle is here. So now we can again just pull it out and. Yeah, just take a artery forceps, please.
Where is the needle?
See, needle is here. There is no problem with the needle. It was outside and we closed.
Oh, how did it go there?
Yeah.
That's happened for the first time. That's why Manuel is here. So we can, and he also does not have this. Manuel, can you see the needle is here? Stuck.
No, take on the light.
Yes. Yeah, I can see.
Okay.
So we have to check if the instrument is okay, or we need to exchange the whole instrument. Maybe.
Yeah, I think so. You are correct. We'll exchange
and also Mohit, as the suture is inside the patient. Mohit, are you following me?
Absolutely, I'm following you. Please go ahead.
Okay, as the suture seems to be inside the patient.
Yeah.
What we're gonna do is that we're gonna cinch it. By doing that, we're gonna pull the suture inside the cinch and slide inside the patient, and we follow with the scope, and we're gonna cinch it.
Yeah. No, we could have
suture inside or no?
We would have done that.
There is no suture inside.
There's no suture inside now. We are changing the system.
Oh, okay, got it.
No, we don't need a cinch, Manuel. We got the suture back out. That's why we did that. What we did. Now we're gonna go with a new system.
And before you put the system, Mohit, one thing you can do is use your scope to clean and to watch to see what is the situation inside.
Okay, let me do that for you, and then I'll.
Because you're gonna have a better view.
Yeah, sure. Okay. Can you give Manuel the endoscopic view on the main screen now?
Yeah, I have it.
You have it? Okay. Now you can see that this is my first two sutures. Can you see?
So go, yeah, but go up a little bit in the anterior wall. It's up high. You see, it's here. Where the suture was stuck is up here. See?
Yeah.
and you were a little bit higher than
Okay.
usual.
Okay.
You're a little bit
Yeah.
high,
So
a little bit high in the anterior wall on your right side.
this one, this
So
place I
up,
was. Yeah.
yeah.
So that's
See,
maybe,
you
yeah, this place I started. Yeah. So that's too
yeah, it
high.
got stuck.
So maybe
Yeah,
I
but it
start
seems
from,
it's yeah, yeah. But
so,
nothing gonna pass. Don't
yeah.
worry.
Yeah. Yeah. I'm gonna put in the new set again and start it again. Just give me 2 minutes
Yeah.
time.
Thank you very much for showing us.
Oh. So I was talking to Dr. Medev, and I was telling that we have a very important workshop coming up in the month of November, where you're going to
Oh yeah.
demonstrate a sleeve revision. We are talking about weight regain in pandemics, and we have a plethora of patients waiting for us. So I'm almost booking we have 20 patients already lined up for you when you're coming to India in November, and
Oh,
we're going to
thank
do
you.
that show. So that you're going to do, obviously we have a lot of virgin endoscopic sleeves, but we have sleeve revisions also. So you're going to demonstrate, and Dr. Higa going to moderate that session. So that's going to be a very interesting session where we talk about managing
Yeah,
weight
indeed,
regains during pandemic.
indeed. And I think this is a window of opportunity, my friend Amit, that is the weight regain after procedures, because on the pandemic, every single one of us lose our minds a little bit, and so many patients are getting back to us with weight regain in situations like sleeve gastrectomy. They want to keep the sleeve gastrectomy, but they put some weight on the pandemic, on the gastric bypass, mini gastric bypass, whatever procedure, and it's natural. It's natural because this pandemic forced us out of what we should be doing, that have a more healthy lifestyle, because we were confined. And what I'm seeing here in Brazil is the surge of those patients of weight regain needing something to be done. I don't know what you see in India, but it's a window of opportunity to broaden up our penetration with the patients, or the way the patients see what we are doing. Amit, do you think that it's a window of opportunity? Do you agree, or you see it differently? Because you are so wise and you have seen so many things
So
during
Manuel's question
the
is
life.
that
Yeah.
you think that we'll have a lot of patients now coming to us with weight regain, because in pandemic nobody was exercising, and
Yes,
so can we revise them by using an endoscopic method? So do
yes,
you
yes,
see this
yes.
as an opportunity for you to advertise that if you have a sleeve gastrectomy done in past and you regain your weight during the pandemic, come to us, we're going to do
Yes,
some help to you with the endoscopy, because nobody wants to do a surgery again. That's what is this question.
yes.
Do you see an opportunity?
I think definitely there is an opportunity, Manuel, as far as weight regain is concerned. And not only that, but another thing which has changed after the pandemic is that people have become more fitness conscious.
Absolutely, I
And
agree.
so what has happened is, even those who would not have got anything done probably now will be willing to get it done.
Agreed.
No, Manuel, what's the one industry in India that has grown by leaps and bounds during the entire pandemic? Can you guess?
No, please.
Okay, so that's the cycling industry, the bikes. In India, we have the uh, bike owners enjoying, because there were a million bikes sold, because people want to go on road and they just want to lose some weight, because they realize that and in fact the media also publicized it in a very right way, that most of the complications which are happening during the pandemic season are happening because of, I think we need to change the needle exchange catheter also. Just change this. It's a new one. Okay, it's a new one. Okay, that's fine. Okay, let's go.
Yeah, do some
By the way,
exchanges to
time is
see.
now up.
It's a little bit. Can you
Actually,
before you go,
it's the same issue.
before you go, just a moment, Mohit. Before you go, can you just no, don't do that. Oh, okay, you did it.
Okay,
I
now
wanted to
I'm able
check
to.
if it's the exchange.
No,
Mohit,
no.
You see,
I'll have to go.
let me
Okay.
just see it. Okay, now exchange the needle
Okay.
once. Okay, again. Okay, now it's gonna work. You see, you're not being able. You see, good. No, you're not being able to exchange.
No, yeah, it's happening. It's okay. It's fine. I can see.
Yeah, but you have to click the blue button to see, and it's not exchanging. And now you're good. Now you're good.
Something is wrong in the alignment.
Okay.
Hmm?
Something is wrong in the alignment.
Something is wrong in the alignment.
Yeah, and it's a new device, so it's very weird.
It's a new device. That's why me and Abhishek are concerned because, anyways, I think we're gonna do good now. We are here, and I'm putting some air inside so that I can see in a better way. And it's
Yeah.
When can we talk again?
I'll give you a call in half an hour. Once I finish, I'll give you a call.
The car will be there. No?
Yeah, yeah. Vinny ko bolna sir ko. Okay, Manuel. So let's start.
Take this one.
We were
Okay.
here. I think you were making the point that I was at the wrong place. I was a bit high. I'm gonna start from a new place. Just a minute. Okay, that's fine. I'm gonna start from here. Let me start. I think now I'm able to exchange. Yeah, now it's going well. Okay, now that's fine.
Cool.
Okay. I think it has to do something with the device. I think this device is made in a way that uh, maybe the thickness of the needle is limited to certain kind of tissue, and once we take more bite, a thicker bite, it doesn't work that way.
Agreed.
Because once we become more and more proficient with this, the bite which we take, the quantity of bite which we want to take continuously increases. So maybe the needle, I don't know.
Yeah, it's sometimes it seems that they need to like get warmed.
Like for example here, and I sometimes get a feeling when I know you must be getting it, like you must have. This is a hunch you get, or maybe a feel in the hand when you realize that
Good.
the needle is not going to
Yep.
exchange.
Yes, and it's like very technical answer to do that. So if you accumulate tissue on the smaller tower, on the right side size tower, sometimes it's not exchange. If you are able to see, as you're seeing right now, the small tower is 100% sure that you're gonna exchange. Make sense?
Yeah, true. Makes sense. Yes. Okay, so we are there. This is an area we should not touch. Maybe I just move a scope a little bit back so that I can tubularize like you taught me. Maybe this, I think. Yeah, maybe. Okay.
Very good. I like the move.
Yeah. I hope I'm able to exchange. So it exchanged.
You are. You see, sometimes those things during surgery or doing procedures just come to us to keep us sharp.
Yeah. I mean, what I
not to feel
realized.
very comfortable.
What I realize is that in endoscopy we need to keep some patience. So it's
Indeed.
you have very less control here. It's not like surgery. In surgery, in laparoscopy, you have a little more control. Here you have a little less control, but that's fine. So you have to be a little patient and maybe understand the anatomy a little bit more. It requires more skill to do an endoscopy. Now, for example, I know that this is not going to exchange. You know why? Because I think
because too much tissue on the right side.
Yeah, absolutely. So what I do is Abhishek wants me to move. Can you see my
Yes, you can do
monitor?
that.
And I'm here. I'm seeing the other monitor. I get
Now
back.
unrotate your body. Perfect. Now you're able to do it. Good.
That's
And let me tell you this: what you just mentioned is very important because on endoscopy we have just one chance. We have 1 or 2 channels. We cannot exchange our hands. We cannot exchange our position.
Yeah.
And very different from open surgery and laparoscopic robotic that you can
Very,
have
very
multi
different, very
angles.
different, because we have a lot of chances there to change things, you know. Here, if you
Exactly.
have,
And
if here you don't
yeah,
have so many chances, plus you need somebody who understands the entire concept, because now see again the same problem. But I'm gonna exchange this.
but now we can exchange because
I
you're
think
seeing
so.
the tower. You
Yeah,
will exchange. You see,
yeah, I am able to. Thank you.
just trust on the old fellows. Eventually, we can have some experience.
Yeah, yeah. No, you know, I think there are certain kinds of tissue that are more sticky and more what can I say, more thick than others.
Yeah, thick and muddy, like
Muddy.
muddy.
Yeah, yeah. Like
Yeah,
sometimes,
muddy. Muddy
you
might be
do
the word.
like you know what, I give an example that when I run on the roads these days, sometimes the roads to the shoes feel very nice, you know, very
Yes,
nice grip. Like I'm running with my new shoes, very nice grip, beautiful kind of, you have the ground feel, you know what you're doing, and you know, on some days you feel as if you're running in the air. So
exactly.
it depends upon the anatomy you are working. It depends upon the place you are working, how the tissue has been oriented to, and what sort of tissue uh, morphology you are encountering. That determines what sort of problems you're going to encounter at the end of the procedure. So that's what is important, and this is why the perception in the hands play a very important role. The perception in the hands is slow to come, but once you have that perception, you get a feel uh, that you're gonna do good. See now, example, I was not able
Yeah.
to exchange it, so now I'm gonna go here. This a little bit.
Yes, and
Okay,
Mohit,
now see
when you
this.
it's not coming, so you have to go there.
Yeah, so I'm
Good, good.
gonna.
Now it's coming.
Yeah, I hope I'm able to
And
exchange it.
it
Yeah,
you are you are. And it's
one
very
more.
important what you just say, that if you say to a surgeon that in endoscopy we have the tactile feedback sensation, they're gonna joke with us, say, though it's not possible. But indeed it is. You develop, and you can ask, we can ask Amit, this tactile feedback sensation. It
Oh,
is not that we can do it, and it's a very important that you develop this
it's a very
capability.
important sensation to develop, specifically because I think that's one of the things which and you know, when I was doing some initial cases with you, it started to develop in my hands. But this is easy. I'll tell you a very difficult situation. So Manuel, I was doing my robotic training, and I went to IRCAD in 2011 for this training. And when I sat on the robo, I was tearing the intestine of the swine like anything, and I damaged at least 2 or 3 pigs. And by the end of the training of 2 days, I realized that the sensation has started to come in my hands now, and now I'm not going to do that mistake again. So you know,
It is what had to be developed, and people think that we are funny, that we, when we say at the very beginning, you have to develop this sensation, that they think they're not possible, but it's something that's real.
yeah. So that's my tube. I'm going to pull it back. I
Yeah,
think
watch it and watch it and watch it.
I think I need one more.
Yep, at least one, a single layer of sutures
Yeah, a
maybe.
single layer
But
maybe.
before you do that, can you clean that for us with
Yeah,
water jet?
I'll clean the entire thing. Yeah, that's what I'm going to do.
Thank you very much, sir. And now you can put more like a water jet and try
Yeah,
to
I'm
aspirate
taking
the
a water jet.
clots.
Absolutely. I'm going to take a water jet.
Water jet is very important for this procedure. I think it's really helped clear and let us know what we are. You can do a suture, but not gonna be that easy.
I'll do that. With you, everything is easy. You are there to guide me, so I can try this.
That's what we're here for, sir.
Yeah, so I know it's going to be a little tricky here. I have to do some dancing maneuvers like you taught me, but let's try. As long as we can take one layer or so, I think I should be fine. So
Yes, and I'm sure you're gonna get it.
yeah, I'm confident of getting one. एक मिनट, एक मिनट. Okay, let's start.
Cool. Go for it.
So I know I have some fluid there, but that's fine. I'm going to be still working in the, like you work in the mud, you know, you have to get a
see?
coin from the mud. Patient is light. Can you give some anesthetic agent? Otherwise she'll run away. Okay.
Good. Good bite. I like this one. Another thing that might make some people nervous or uneasy is that we sometimes put our helix without really seeing where we are going. But the anatomy is already done, no? The anatomy have to be in your mind, and that you have to be sure that you have this perspective beforehand. Don't you agree, Mohit
Yeah, you know,
and Amit?
you know, when well, Amit has gone to the hotel. He has a webinar. So he is back to the hotel. I am alone to interact with you.
Okay, perfect.
Just to answer your question, I think I absolutely agree that most times when we have a lot of blood mixed with water here in the fundus, we have to have a 3D orientation of the anatomy. And as you can see, that's something which we learn when we do these cases, and we sort of, now see, again, I'm going to make sure that I take a bite head on. So we're going to push, and we're going to make sure that I take a nice bite so that I'm not, okay, that's, I think I should be able to exchange. Let's see. No. Okay. Let me take once more. Okay, let's take from here.
And Mohit, can you tell me about, in terms of results, if you have any cases of bleeding that you have to get back?
No, never.
So the profile, safety profile of this procedure, I think is very good.
It's where I never had a patient, you know, we had some patients, like for example, I can expect this patient to have, I can expect this patient to have a little bit of maybe some hemoptysis or so, but I don't expect this patient to have any other problems, you know, or maybe related to bleeding, because that's something which we don't expect. You know, usually this bleeding is going to stop maybe within half an hour or so, and it's not bleeding actually. It's a little bit of blood mixed with fluid, the gastric fluid.
Agreed. So,
So
you're gonna do your 2 less stitches there, no?
Yeah.
Good one. Very nice. Like it.
So now I have a choice. I can do it this way, or I can go all the way back. Can you see?
Yes, I can see. And the most important, that you have to return to your original position. Otherwise, the needle gonna get stuck.
Absolutely. That's what I did. I immediately returned back. I think I can go up. I can come a little medial, and I can go up. Okay, let's try and go medial. Okay, that's good. Yeah. And now, Manuel, can you see my position?
I can.
So this is how.
Sometimes you have to go there.
Yeah.
And this is very important to do that. If you refuse to do that, or you don't learn to do that, you're not gonna able to achieve the right position to do the best stitches on, especially
now
on the fundus, as you're doing right now.
I'm gonna go a little bit. Okay, maybe this. Okay, that's okay. Okay. Maybe, and then you see I have a twist. And I'm gonna take this. So I'm gonna go here.
Perfect.
Okay.
Perfect. And that's gonna be your last one.
Yeah, one more and I'm done. Okay. So here.
Right there.
Yeah, so now see, right from the pool, I know what my anatomy is.
Yeah.
I'm gonna go. I'm just guessing it, but I know by God's grace I'm gonna be fine. It's a twist. Lock it.
And it's a moment of faith, but not faith in like something else than your
one more
anatomical knowledge.
No, that's fine. Now see, again, I'm gonna go here. I'm gonna go right into that pool of blood. You see my position is there. I gave a twist to my scope, a little one, like that maybe.
Good.
Come down with the wheel, lock it. I think, no, again. Let's go again. Let's give a twist to the, yeah, take it now.
Good.
You may have to give a twist to the, yeah. So now I again pull it back. That's my tissue. Now I'm done. Now I can exchange. Yeah, I'm exchanged. So, okay, I can drop it now. What do you say? Do you want one more? There, top?
No. Okay. We're good. You're going to see that you're surprising. Okay. You're going to see that it's good.
Okay, I just thought if we... Okay.
Yeah. Yeah, we just take the big tower out of the equation. So move your tower
Yeah.
to the right side of the screen. It's gonna be perfect. Left side, good.
So I'm gonna suck this and gonna tighten
Yeah,
it up a little bit.
you're gonna be surprised with the shape of this sleeve. Gonna be very good.
Okay. 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 It's fine. Okay. Mhm. Okay. So that's it. I'm gonna just close my.
Device, remove, exchange, and then go back and watch everything.
Okay. Okay. I'm gonna go back. I remove this. Okay. Okay, so here we are, and I'm starting again to do a check endoscopy as to what we did. This is the esophagus. We need to put some air inside so that we are able to see what's happening there. I'm gonna clean my
Let's
scope.
wash. Yeah.
Wash, wash,
Let's
wash.
wash it with the water jet a little bit.
Yeah. So that's my pylorus. Can you see?
Yes, I can.
It's there. And then I'm gonna come back. So that's my tube. I'm gonna pull it
Yep.
slowly. Slowly back, 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 back.
To the esophagus now.
Is that
Good.
okay?
Yeah, you see, you go up to the fundus. It's very good.
Yeah, there's no fundus. In fact, it's very small. See, there's no fundus there.
Yeah, that's very good indeed.
Thank you.
Was a very good case, Mohit. I think we have the opportunity to see some very good sequence of bites, clearly define it.
Thank you
We
so much.
also could see some troubleshooting that is good to people understand that it happens as in surgery, as in any procedure, and to keep calm, never lose the patient, and you see it was solved with no problem, and at the end you have this very beautiful procedure.
Thank you, Manuel. Thank you so much for giving your valuable time. And I think the quality of vision at your end was okay.
Yeah,
I think
let me congratulate you and your whole team to the effort, because the quality of image is outstanding. The quality of sound, the quality of the broadcasting is awesome.
thank you,
And
thank you.
please send my regards to all your team, Abhishek, Winnie, to Amit,
So Abhishek is
your
saying hi
father,
to you.
your
Abhishek is
brother.
here.
Yeah.
And Vinny is outside. She is trying to micromanage things which I spoiled. So, and Dr. Phoebe said hi to you. So, see
Oh,
you, Manuel. See you
yeah.
very soon. And I'm going to be in touch with you. God bless. Bye-bye.
Bye-bye.
Thank you.